So I'll go ahead and introduce you to our audience today, and then we can get started. Okay, Dr. Al Khal?
Yes, sure, please.
Okay, so welcome everyone. On behalf of the Regional Office of the Association of Academic Health Centers for the MENA region at the American University of Beirut, we are delighted to have you all participate in our webinar today that will be looking at the Qatar's perspective of COVID-19. Our guest speaker today is Dr. Abdullatif Mohamed Al Khal, who is the Deputy Chief Medical Officer and the Director of the Department of Medical Education at Hamad Medical Corporation in Doha, Qatar. He also serves as a Senior Consultant in Infectious Diseases and Head of the Infectious Diseases Division, Manager of Qatar's National Tuberculosis Program, and the Director of Qatar's Clinical AIDS Program. Dr. Al Khal earned his degree from the Royal College of Surgeons, completed his residency and fellowship training in Connecticut, USA, and is American board certified in both internal medicine and infectious diseases. In addition to his clinical roles, Dr. Al Khal also serves in an advisory role to several public health programs under the umbrella of the Qatar Ministry of Public Health. He has held a faculty appointment as Associate Professor of Clinical Medicine at Weill Cornell Medicine, Qatar since 2007, and also holds the title of Clinical Professor of Medicine at Qatar's University College of Medicine, as well as serving the college's founding Associate Dean for Clinical Affairs. Dr. Al Khal remains active in research and publishes regularly with his interests spanning the fields of internal medicine, infectious disease, pharmacology, and medical education. Please join me in welcoming him in today's presentation. Thank you. You can go ahead.
Thank you, Ms. Ala, for the kind introduction, and good morning, everyone. I'd like to thank the AAHCI for their kind invitation for me to share the Qatar experience and our response to the COVID-19 pandemic. I'll try to describe the epidemiology of the pandemic or the epidemic in Qatar and the governance structure that we established to deal with the epidemic, and then share with you some figures, and then at the end, the reopening plan for the country. So, as you know, since the virus has emerged in China end of December, it has affected all countries with confirmed cases reaching and exceeding 8 million, not counting all the infected people who were not tested, or who are asymptomatic, or who did not make it to the health system. In addition to more than 400,000 deaths. For some reason, the slides are not changing. Yeah, it's changing now. The start of the epidemic in Qatar has two important dates in the history of the virus in the country. The first case that was diagnosed was on the 28th of February, and this is among returning travelers from Iran, where about 130 people were evacuated from Iran, the Islamic Republic of Iran, Qatar on the 27th, and all of them were put under quarantine and they were tested. The first positive case in the country was on the 28th, out of those who returned from the Islamic Republic of Iran. And that was considered as the first imported case. Later on, in the next few days, we diagnosed additional positive cases among this group of returning travelers. And in total of 130 or so returning travelers, we found 8 positive cases. But the first case with no history of travel in the country was diagnosed on March 8th. And this was in a laborer who presented to one of our hospitals with severe acute respiratory infection. And this was the beginning of the threat in the public health work that was done at that time to trace the contacts led us to more positive cases, and the additional positive cases led us to more and more positive cases. And since then, we've been diagnosing um, many cases every day. Uh, we reached almost and exceeded 2,000 positive cases per day at some point during our peak. The country put a governance structure to be in a better position to respond to the epidemic. And the governance structure we find to be very helpful. This is the final shape of the governance structure. When it started, it was not exactly like this, but we modified it as we progressed in the epidemic, and we built on our experience, and that helps us refine the governance structure in a better way to allow very rapid decision making and dissemination of information and communication across the different entities. So on top of the national health response to corona, it's the Minister of Health, and the Minister of Health reports to the Cabinet and to the Prime Minister on frequent basis outside of the Cabinet. Under the Minister of Health, there are two main committees. One of them is called the National Multi-Ministerial Committee, which has representatives from each of the ministries. And this committee initially met 3 times a week and took important decisions or made important recommendations to be escalated to the Prime Minister or the Cabinet. For example, the National Multi-Ministerial Committee took decisions on closing businesses, people working from home, closing mosques and worship places. So decisions like that. The other important committee that sits under the minister is the Health Strategic Command Group. So this group makes strategic decisions on, for example, the testing strategy or the quarantine strategy. What do we do with returning travelers? What are the predictions for of the epidemic going forward, and how can we be better prepared for it? What important messages should be communicated to the public? So all those decisions are taken at the Health Strategic Command Group, and the either decisions are made or recommendations are raised to the minister for endorsement and further action. To facilitate the work of the strategic committee so that it remains strategic, 2 subcommittees, tactile operational committees, were created. One of them is the Healthcare Delivery Committee, which is responsible for expanding the healthcare capacity to deal with the increasing number of infected cases. So this committee deals with increasing the number of ICU beds, the acute care beds for severe cases who require admission but not ICU, and they're dealing also with additional facilities for mild or asymptomatic cases. So this committee is typically dealing with the hospital side of things, recruiting more staff, redeploying staff, changing the way normal business or normal care is delivered through the healthcare system, procuring more PPE, and so on. The other tactical group that sits under the Health Strategic Group is the Community Services Group, the Tactical Command Group related to community services. The responsibilities are things like quarantine facilities, tracing and tracking contacts of positive cases, tracking those who test positive and that are still in the community, and trying to bring them into the healthcare system, and doing surveys and screening in the community. So both leaders of those two committees sit as members in the Health Strategic Command Group. To support the function of the Health Strategic Command Group, we created a scientific research and a scientific reference and research team, SRRT for short, that will review all the latest literature in terms of, for example, quarantine, the latest evidence on testing, and for example, CT values, and what does that mean, for how long people should be on isolation, what's the best treatment to be used, and what's working, what's not working. And then it will raise its recommendations to the Health Strategic Command Group. The SRRT meets 2 to 3 times a week, which is similar to the meeting of the Health Strategic Group, which meets 2 to 3 times a week. This is also supported by a PPP team. So this is the planning group, where they provide technical support and administrative support to the Health Strategic Group and to the Scientific Reference Group. 2 other groups were created: the Communication Group, which works on the communication and the important messages and the media that should be used to communicate with the public and with other groups. And they did a great work in increasing the awareness of the public through different video clips, pamphlets, and other information using the social media or using TV or radio. So we found that to be very helpful. And the logistics team that is responsible for the resources that are needed to support all those activities. This is a photo of our Ministry of Health website, where we display all kinds of dashboard with all kinds of information for the public, and this is updated daily. So if I walk you through this, the top left part shows you the number of people tested so far, which we exceeded 300,000 tests, individuals tested, and the number of tests that we for individuals that we do every 24 hours. The second one, which is the top middle square, which shows at the bottom line, shows how many people tested positive so far. As of yesterday, it was 82,000 plus, and it shows you also how many are currently active and under isolation or hospitalization, which is 21,000, and the total number of people who tested positive in the last 24 hours. The one to your right upper corner shows the number of people who recovered so far, which is 60,000, and the number of people recovered in the last 24 hours. The bottom row of squares, the one to your left, shows the number of deaths. We reached 80 deaths as of yesterday, and the number of deaths in the last 24 hours. And then the one in the middle, the bottom, shows the number of people who are currently in acute hospital care. So out of the 21,000, 1,147 are in acute care. These are patients who need oxygen and treatment. And next to that is the 143, which is the number of acute hospitals in the last 24 hours, which is an indicator that we use to measure the activity of the epidemic in the country. And then the last one to your right hand lower corner, it shows the number of people who are currently in the ICU and the number of people who were admitted in the last 24 hours to the ICU. So this is to give you an idea of the age breakdown and the gender breakdown of the cases in Qatar. As you can see from the left upper hand graph with the blue bars, that most of the people who get the infection in the country are those between the age 25 and 44 years, and this tends to be most of those people tend to be the crafts manual workers in the country that work in the industry, in construction, housekeeping, and so on. But also reflects the same the pattern in the rest of the population, Qataris and the professionals. So most of the infections tend to be among young people. And you can see it in the below the graph, that line which shows the mean. The mean age is 34.6, around 35. And then the pie, the chart, the pie chart on your right, in the top and right corner, shows the male-female breakdown. It's predominantly male. 87% of the cases are males, and 13% are females. It also reflects the structure of the population, because it's mostly male population. And the graph, the pie chart at the bottom shows you the recoveries versus those who are still actively infected, and shows that about 3/4 of the cases diagnosed in the country have so far recovered. This is a graph from China, which shows to try to illustrate the reproduction number of the virus. The reproduction number, as you know, is the number of infections that happen per index case. So if somebody is infected, how many people would he or she transfer the infection to before he recovers? So in China, when it started in Wuhan, the reproduction number was 4, and then quickly declined with preventive measures, social distancing, lockdown, and so on. Quickly fell down to 2, and then below 1. So if the theory is that, or the principle, if you keep the reproduction factor below 1, then you can control the epidemic, and theoretically at some point you can stop the transmission of the virus in the community. In Qatar, when it started in March, we think that our reproduction factor was around 5, and then with control measures quickly fell to 3. And then about 5 weeks ago, it fell to 1.2, 1.1. And today, or as of Monday, 2 days ago, when we started lifting the restrictions, our reproduction factor or number came down to 0.7, which is a safe margin for businesses and activities to gradually start going back to normal. These graphs, the flattening of the curve, as it's called, if you look at the left upper graph, which shows you the one in red shows you what would have happened in Qatar if we didn't do any interventions, and the one in blue shows a 70% reduction of the numbers of cases because of the measures and rules that and restrictions that we're implementing. So it resulted in significant reduction of cases in the country. Otherwise, it would have overwhelmed our healthcare system and would not have been able to handle all this excess number of cases. This is the number of daily cases by swab date, not by testing date, as of June 14. And you can see from the blue bars and the green curve that we peaked around towards the end of May, where we had the highest number of cases. We exceeded 2,000 reported cases per day, and this is about a week after the predicted peak by the epidemiologic modeling that we did. So we think we reached the peak around 21st of May, and the number of cases takes a few days for the health system to discover those positive cases who got infected around the peak date. So you will see a gradual build of cases until the end of May, and then we started seeing decline in the number of daily reported cases. This continues to be the situation, and the numbers seem to be declining. This is the result of all the preventive measures and the lockdown that was implemented over the last few weeks. This is for Qatari nationals. It's following more or less similar curve, where we reached the peak slightly after the peak for the country, the entire country. So we peaked for the Qatari nationals in the first week of June, and then we started seeing a decline. The cases among the Qataris and also the white collar, which follows, the professionals, which follows similar curve, happens mostly in family clusters, particularly during Ramadan, where families tend to visit each other and have iftar together. Although that happened in a limited way, it did result in a noticeable increase in number of cases among Qataris and the professionals. This is the 7 days moving average of the activity of the virus in the country, which gives a better indication versus the daily numbers. And again, it's showing the same thing, and it's showing that we peaked towards the end of May, and then we started seeing a decline. This is the acute admissions, and the ICU admissions, and which we think are more accurate reflection than the daily number of discovered positive cases. The acute admissions, we reached a peak of 323 admissions in one day, which was in the around the 20th of May. And then the average started to decrease gradually. And as of June 6, we had 128 admissions. So that's in one day, the acute facilities. So these are people who need oxygen and treatment and monitoring for a few days. So there is noticeable drop in the number of acute admissions. And the graph at the bottom is showing you the admission curve for the ICU. I'll give you some more details a little bit later. This is just to show you the actual number of cases that we admitted versus the predicted numbers. So it's a reflection of how accurate the predictions were. If you look at the far left, you would see that in the orange bar, the predicted acute hospitalizations, if we assume that each admission would require 8 days, versus the gray bar, which is the real situation. And you can see a very good match there. The same thing on 1st of June. The prediction and the real situation do match. So our calculation and epidemiological models we think are fairly accurate in predicting the burden on the healthcare system. This is the number of ICU admissions. We peaked at on May 30th or 31st, where we had 27 ICU admissions in one day. And then we started seeing a decline on the average number of admissions, and this decline continues. As you know, ICU admissions lags behind the acute admissions by about 1 week. This is just to describe the numbers, the recoveries in Qatar. Until end of May, we were using a strict recovery definition criteria, which is people who initially tested positive must have 2 negative PCRs 24 hours from each other after they resolve their symptoms. So this resulted in very few recoveries. And now we know that most of the patients after 10 days, even if they say of symptoms or of diagnosis, although they continue to secrete the virus and that it can be picked up in PCR, most of this is non-viable and non-infectious. So we changed our recovery criteria using the time-based criteria. So anyone who completed 2 weeks since they first had the symptoms or diagnosed and at least 5 days with no symptoms, we consider them as recovered. So this resulted in sharp increase in the number of recoveries because we had many patients in the system, either in the acute setting or in the isolation facilities that met the recovery definition, and we started discharging patients, those people over a short time. And this resulted in a big jump in the number of recoveries. At this point, we are adopting the 2 weeks, and we also started using the cycle threshold or the CT values for the PCR test results to also help make a differentiation for when we diagnose new patients to see if they are actively infected or they actually have recovered from the infection and that they are positive, but they are at the end of the infectious cycle. This is a summary of the number of people who were admitted to the intensive care unit. We had a total of 1,110 people admitted to the intensive care unit. 838 of them were transferred out. At this time, we have about 244 people in the ICU. Those who are currently intubated are 123, and we have 17 patients currently on ECMO. Out of the 1,110 patients who were admitted to the ICU, our total deaths is around 80, which gives us a very low mortality rate. The graph on the top shows you the breakdown of the age group of the patients who were admitted in our ICUs out of those 1,100 or so patients. As you can see, the biggest proportion of our ICU patients are those from the age group between 40 and 60. And most of them tend to have chronic conditions like diabetes, hypertension, to a lesser extent coronary artery disease, and other conditions. Fortunately, we have a smaller number or percentages of older people entering the ICU. I think this is a reflection of the extra caution that the community is taking in trying to protect the older population. But also, in general, Qatar is a young population. This is just to give you an idea of how many people were intubated out of this was out of 949 patients. Out of the 900 or so patients, 541 were intubated, more than 50%. The remaining did not need mechanical ventilation. So you can imagine the burden this puts on the ICUs in terms of equipment and personnel. This is our experience with ECMO. 72 COVID patients were evaluated for ECMO. 48 of those were declined. ECMO, they found them not to be suitable for ECMO. 28 ended up being on ECMO. Most of the patients who were on ECMO were between 40 and 50, followed by the group of 50 to 60. And you can see that majority of the patients on ECMO have either diabetes or hypertension or both, but some of them did not have comorbidities, indicating the severity of the infection, the severity of this virus, even in patients who don't have chronic conditions. Out of the 28 who went on ECMO, 10 were decannulated and eight of them were extubated and sent out. So far, we are getting good results with ECMO. We still have 17 other patients on ECMO. This is again the predicted versus the real situation for ICU admissions. And as you can see from the far left of the graph, between the orange bar and the gray bar, there is good match. And the same thing on 1st of June. There is a reasonably good match between the predicted number of admissions to ICU versus the real number of patients in the ICU. So those mathematical epidemiological calculations are very helpful in preparing the ICU beds based on the numbers that are anticipated to need ICU care at any given point in time. This is the mortality rate in Qatar, and we try to compare ourselves to other countries. And here we are comparing Qatar to Italy and France, and you can see that our mortality remains very low for different age groups. Our mortality at this point is less than 0.1% of confirmed cases. So we are very pleased with those results, and we are trying to keep it that way. We think there are several factors that are contributing to this, including the excellent intensive care, quality of intensive care that we provide for the patients, the proning position, frequent use of proning position, plasma. We are one of the first countries in the region to use donated plasma from convalescent patients for treatment. We transfused more than 170 patients so far with plasma. Use of aggressive treatment protocol, including use of interleukin-6 inhibitors like tocilizumab to control the cytokine storm. But I think in general, the high quality of the intensive care services that we provide has something to do with it. This again is the figures for deaths in Qatar. If you look at the bottom row, you can see that figure of, this is when we had 33 total number of deaths of 33 patients. If we use the Italian model, then we should have had more than 400 deaths. And if you use the French model, we should have had more than 500 deaths. So it looks like we compare favorably when it comes to mortality. This is the cumulative and daily deaths due to corona until the 14th of June. And just to give you an idea of the daily number of reported deaths. And the blue curve is the cumulative number. Our death rate is estimated to be 0.89 per thousand. And this is also to compare Qatar mortality with other countries in the region and in other countries worldwide. And you can see that we are close to Singapore, followed by Oman, Saudi Arabia, Emirates, and Kuwait. And the region in general is doing better than the rest of the world. This is another way of looking at mortality, where Qatar and Singapore are way down on the curve compared to other countries in terms of mortality. This is the Google Mobility Index that we used as a rough indication of the closeness of people or the implementation of social distancing. And you can see that we did very well on 17th of April. And then the numbers fluctuated up and down. And now with the reopening, the physical distancing indicators show that people are coming closer together. We are watching the situation carefully and looking for any signs of recurrence of the virus. This is the concept of using CT values and on PCR testing. Now we are started looking back at our figures and see out of all those who test positive on daily basis, how many of them have a CT value of 33 and above. And we consider them as non-infectious. We consider them as having got rid of the infection. And we think that anything between 25 up to 50%, depending on the sample, that may be not infectious at the time of diagnosis. And this has many implications on the resources. It means that those people you don't really have to isolate. You just have to check on them to make sure they are not sick and maybe ask them to stay another week at home so that, to eliminate any small risk of transmitting the infection to others. This is just to show you the indicators that we'll be using for the reopening. We started the reopening on 15th, which is 2 days ago, where we will use three main indicators. One has to do with the epidemiology, one has to do with the healthcare capacity, and one has to do with the public health. And translates into 9 indicators that will be monitored to see if we should make a recommendation to progress to the second phase of the opening or we should hold. So I don't have the time to go into details, but this is just rough description of the indicators. These are the basic rules that are implemented as we reopen the country, including, sorry, it doesn't reflect very clearly on the left side, but it says social distancing, people adhering to social distancing, use of masks in the public and at work, and this is mandatory. Early detection, so we are now thinking of ways of increasing first our testing capacity, which we already have. We increased our testing capacity significantly, and we are still continuing to increase it. And how can we use this testing to help the reopening plan to avoid recurrence or resurgence of the virus? Ihtiraz app, which is an app that you download on the phone that will help us identify people who get exposed to other infected people. It's mandatory. Everybody has to download it in their telephone, and so far it seems to be helping us in identifying cases, close contacts of infected people who otherwise you would not know that they were close contact just by talking to the patient and taking history from them. And the vulnerable groups, we are focusing on those of 60 years of age and older, and those with chronic conditions, reaching out to them through the primary healthcare system to make sure they are in good health and that we are testing them routinely to detect any early infection among them and to try to protect them from the virus reaching out to them until hopefully we have a vaccine for the virus. These are the opening plans for the country, and it's in 4 phases. Phase 1 already started on the 15th of June, supposed to run for 2 weeks. Phase 2 is 1st of July, Phase 3 is 1st of August, and Phase 4 is 1st of September. And moving from one phase to another will depend on the 9 indicators, the KPIs that I described a little earlier. This is just to give you an idea what will open in Phase 1, and Phase 2, and Phase 3 and 4. And it's a graduated, staggered reopening of businesses and workplaces and other activities that will be increasing gradually over the 4 phases. And this goes on for transport, for example, when we will be allowing people to come back and what are the conditions for re-entering the country. Um, and again, for outdoor professional sports and for education and health, gradual return of activities. And for the malls and other businesses, how are we returning to normal? For example, malls in phase one, which is these 2 weeks, which we are in, there we are allowing 30% of the malls to open, provided that shop size is 300 square meters and above. And we are mandating 9 square meters per customer in any shop. So if a shop is 90 meters square, then they can maximum have 9 customers in the shop at the same time. All of them wearing masks, of course, including the salesperson. And this will increase gradually over the next few phases. And again, this is for business and leisure. So I think this is my last slide, yes, and I'll stop at this. Thank you very much for your attention. I'll be happy to take any questions if there is time.
Thank you, Dr. Al Khal. That was excellent. Really appreciate your time and effort for the presentation. I'm going to go ahead and open the floor for discussion. If you have a question, you can either answer it in the Q&A in the chat box, or you can raise your hand and I will unmute you so you can talk. We have one question from Mahmoud Halabi. I'm going to let you talk. Can you unmute yourself? Yes.
Yes, I did. Good morning, everybody. Can you hear me?
Yes, we can hear you.
Okay. First of all, I would like to thank Dr. for the Qatar for their immediate response and for the proper actions that they have taken to contain the virus and reach the stage which is at the moment firmly controlled. I have 2 questions, if it is possible. One, is there any sequencing for the genomes of the strains that are going on in Qatar? So that's one. Secondly, is there any plans, or I probably missed it, I don't know, to see how widely spread the virus in the community, like a fast test or antibody tests to see what's the percentage of the population who are already immune to the COVID-19? And thank you.
Yes, thank you for your questions. Both are very good questions. Yeah, we have a collaborative between the Ministry of Health, the healthcare system, and the universities in Qatar on sequencing of the virus. So we are working with Qatar University and Cornell, particularly in this regard, and we sequenced many of the isolates so far, and they are shared on the internet. We are also monitoring any mutations in the virus over time to see if it's changing. Regarding the percentage of the population that are already infected, it varies on the subpopulation. So among the crafts manual workers, a higher percentage of the workers are infected compared to the Qataris and the professionals. So among the Qataris and the professionals, we think based on the numbers we have that 90% of them have not been exposed to the virus, 90% or maybe more. Whereas in the crafts and manual workers, the percentage is that anything between 25 and 50% of them have been exposed to the virus, depending on the location and the nationality. We are still in the phase of doing more serologic testing at community level to have a better understanding of the spread and the attack rate of the virus.
We have time for a few more questions if anyone wants to type anything. Okay, I think that will conclude our webinar for today. Thank you everyone for participating. We will share the recording online on our website. And we have one more question. How many cases were among healthcare professionals?
I think I don't have the number off the top of my head, but I think we diagnosed more than 500 healthcare professionals. Percentage-wise, the percentage remains small because the number of healthcare professionals working in the public health sector is big. It's like nearly 40,000. So percentage-wise, it's a small percentage. And we think that most of the healthcare professionals acquire the infection from the community because, you know, they are also community members. And when they are at work, we mandate PPE, N95 masks and gowns and so on. When dealing with suspected or confirmed cases, or less restrictive PPE or lower level of PPE like surgical masks and gloves when working in other areas. But in the community, of course, like any other members of the community, healthcare workers are at risk for infection. So we think most of the infections were acquired in the community. But we had clusters among some of the healthcare workers. For example, we had a small cluster among pharmacists because they were working in one closed environment and they did not really observe the PPE and the social distance or the physical distancing. And that resulted in a cluster of pharmacists being infected. So we know that they got the infection at the workplace. But recently, over the last few weeks, I would say we had only a minimum number of healthcare workers getting infected.
Okay, I think that's it. Thank you, Dr. Al Khal, for contributing to the effort and sharing your experience and observations in this timely event. Thank you, everyone, for joining. You can check the recording on our website soon. I will be sending an email when it's posted.
Thank you very much.
Thank you.